evening, everybody, and welcome all of you to the 99th live program on orthopedic principles. Today, our guest of honor is Dr. Srikumaran from the Mecca of Medicine, Johns Hopkins Institute, Baltimore, United States. Dr. Srikumaran earned his MD from the Johns Hopkins School of Medicine and completed his residency in orthopedic surgery at the Johns Hopkins Hospital. He performed a fellowship in shoulder and elbow surgery at the Harvard and Massachusetts General Hospital, and also at the Bryan and Women's Hospital in Boston, Massachusetts. Dr. Srikumaran joined the Johns Hopkins faculty in 2011. Currently, Dr. Srikumaran is Associate Professor and the Director of Shoulder Surgery at Johns Hopkins Institute. Today, it's my great honor to introduce you to Dr. Srikumaran for this fantastic lecture on arthroscopic transosseous rotator cuff repair. Over to you, Dr. Srikumaran.
Thank you, Dr. Gopalan, for this kind invitation, and it's great to be here and given this opportunity to speak on arthroscopic transosseous rotator cuff repair, kind of presenting it as a green approach to rotator cuff repairs done arthroscopically. My disclosures are listed on the AAOS website and can be found there, but briefly, we do obtain fellowship support from these companies, serve as a consultant and speaker in addition to stock and royalties. I'm a committee member as well. However, none of these disclosures are relevant to the topic today with respect to transosseous arthroscopic rotator cuff repair technologies. I have no financial disclosures in that arena. So the objectives today are first to simply go over the evolution of rotator cuff repair from its origins as an open procedure, and we review arthroscopic transosseous, fully transosseous, no anchors, and fully anchored approaches. We'll then discuss some biomechanical concepts related to both approaches. We'll compare clinical outcomes, and then finally end with a surgical technique video and a case. In the meantime, trying to demonstrate the green aspects of this new technology. So first, arthroscopic anchorless transosseous rotator cuff repair, and comparing it to an anchored, traditionally transosseous equivalent rotator cuff repair. How does it compare with respect to biomechanics, clinical outcomes, and finally costs? And how do we define this as green? So the green approach, why should we care about this? So some people just very much care about the environment, right? So some people may just don't like to would like to reduce and reuse and recycle materials to make it a more environmentally friendly approach. There's a lot of plastics involved with our disposable implants. Every single anchor and the construct that holds it on, the handle, the delivery device are disposable and get thrown out with each anchor in each case. So maybe we just don't like to waste things. Maybe instead of hugging trees or the environment, you just appreciate money, right? And how to save that in this increasingly constrained environment. So green is about value for everyone. This is Dr. Mattson, and he speaks frequently about this green idea that we should be looking for technologies and approaches that are valuable for everybody, not just the patient and surgeon, but also the healthcare system and the payers of our various implants and techniques. So I'm going to try to demonstrate today how this technology may fit in to this green approach. While we go through these different technologies, I'd like you to consider this Gartner Hype Curve, or often associated with new innovations. Initially, there's some type of trigger, leads to a new idea or technology or implant. Often that's results in a peak of inflated expectations, like more than what we would really eventually see realized in research. But that's often followed by some early results and maybe a trough of disillusionment. So we don't really understand this technology. Maybe it's the latest patch or biologic in rotator cuff repair. How many of those have we already seen to have heightened expectations and hype, only to find later that they not only do they not work, but they were quite costly, and they may have even caused harm in some situations. So we really need to get through this scope of enlightenment, or a period of rigorous research, to understand where these new technologies can fit in. And there we can find where we might be productive, have this plateau of productivity and balance between perhaps a more realistic scenario below this orange line, and maybe too much hype above it. So there's an opportunity to be more innovative when the expectations are low, and as we develop the research and consider different generations of the technology. And we'll review that specifically with transosseous rotator cuff technology. And when we're up here, there's really an opportunity to be more realistic. It's not necessarily this new technology going to be the solution to everything that a rotator cuff pathology presents us. So we need to get to this realistic area based on research and evidence of where we might find a good fit for a new technology. So that's something to keep in mind as we go through this topic. So the basics, just to start, what makes a successful rotator cuff repair? Of course, you must assess the tear pattern and repairability. That's where things start with your diagnostic arthroscopy to evaluate the tear itself, the tendon quality itself, how retracted is it, and how amenable is it to repair and mobility. You want to look at whether an anatomic restoration can be achieved, and when possible, can we achieve that with the least amount of tension and the greatest amount of footprint coverage. And we'll see how that can be a balance, and we're not always able to achieve both of those goals. We want to ensure adequate or good mechanical strength, and that often implies using adequate number of sutures that are well distributed and evenly compressing the tendon to the bone. After that, we consider things such as biology, the footprint preparation, for example, obtaining a bleeding bed for the tendon to heal to, consideration for microchanneling to allow vents for the bone marrow inside the proximal humerus to get near the rotator cuff tendon interface, and then other biologics that we should consider. And we know these are quite costly, PRP and bone marrow aspirate or other bioinductive implants. And then finally, a prudent rehab. A lot of research has gone into the timing of rehab, the aggressiveness of the motion, obtaining motion after surgery, and then when to start strengthening. I think overall we found that longer term studies would suggest that ultimately everyone gets to the same place, and rushing may only result in a higher rate of re-tear or difficulty with recurrent tears early on during that first year. So I do favor a very conservative, slow approach to rehab. And the topic biology is not the focus of this talk, but it's just presented in consideration a more global assessment of how we manage these rotator cuff repairs surgically and what is in our control as surgeons. So ultimately, when we consider these factors, we're trying to maximize value. What can we achieve for what costs? We can spend hundreds, thousands of dollars on various implants and different biologic technologies, but which is appropriate and what's going to present the greatest value to the health system, the patient, and the surgeon. So let's start again with the evolution of rotator cuff repair. What was the original gold standard? Of course, this was an open approach. It was actually done transosseously, simply putting the needles through the tendon and then through the bone. The bone was often soft in this area, as the greater tuberosity would present some osteoporosis locally related to a lack of forces seen with a chronic rotator cuff tear. So it was feasible to put a needle directly through the bone, or use instruments that would initiate a hole that you could make a tunnel through the greater tuberosity and pass sutures, and then obtain your surgical fixation. And there's substantial clinical as well as biomechanical literature to support an open or mini-open rotator cuff repair, good healing rates and good clinical outcomes. However, with the advent of arthroscopy and suture anchors, this technique has overtaken an open approach, and it's become the most popular in most parts of the world. It's less invasive, of course. It has less deltoid disruption or risk of deltoid dehiscence. There's less infection risk, and ultimately is likely been mostly driven by patients desiring this approach, even if the understanding of our evidence suggests the arthroscopic approaches are equivalent in outcomes to an open approach. Patients have driven us to perform this for their own perception of it being superior. And as I mentioned, the outcomes largely are equivalent. One outcome that doesn't get a lot of attention is the infection risk. It's quite a bit less, maybe by a factor of 10 for an arthroscopic approach, and that's quite significant. If you consider an infection in and around the joint to be such a devastating complication, anything we can do to enhance our outcomes in that regard is important. So the decreased infection, I think, is quite an advantage of an arthroscopic technique. So considering the evolution specifically of the arthroscopic rotator cuff repair, initially started with a very simple single row anchor, maybe single suture loaded in each of those anchors, then advancing to a double row that were two rows that were independent, so four anchors in separate areas of the greater tuberosity, medially and laterally, then advancing to what is referred to as a TOE, or transosseous equivalent, also considered a suture bridge technique, where the sutures from the medial row are integrated into a knotless lateral anchor, and those sutures bridge over the rotator cuff tendon into the greater tuberosity. So this is what we'll be focusing on today, is in comparing a fully transosseous approach. We will compare it to what many would consider is now the gold standard, is a transosseous equivalent with anchors approach to rotator cuff repair. And the goal in this evolution has always been to mimic or recreate that original transosseous repair that was completed in an open fashion, and how we could achieve that in a fully arthroscopic fashion. So each repair in this evolution, from a single to a double row to a transosseous equivalent suture bridge, is suggested, at least biomechanically, to be stronger. And this may relate to the number of anchors or other factors that we'll review today. So now we're considering an arthroscopic, anchorless, fully transosseous technique. So this has really come full circle. The benefits of a transosseous repair, as it was originally performed in open surgery with arthroscopy, which is at least patient preferred, and equivalent outcomes. So if we consider the approach to have evolved from an open to an arthroscopic technique, and the constructs to have evolved from anchors and single row to double row, anchors really allowed us to transition to an fully arthroscopic technique. Even though in some cases a mini open approach is still used with anchors, it's the technology that really allowed us to proceed into that approach. So going through single row, double row, suture bridge, and then is it possible, the question remains, to have a fully transosseous technique done arthroscopically? And can we combine the advantages of our approach as well as a strong, reliable construct? So just so we're all on the same page, let's quickly review an anchored repair and how it's typically performed. So this is a depiction of the proximal humerus and an awl making a pilot hole near the articular margin medially, typically one anteriorly and posteriorly for a typical large size tear. An anchor, either thread in or impacted in with one or two sutures, is inserted into the bone. Those sutures are then passed through the rotator cuff, and the sutures themselves here can be tied along the medial border to create significant compression. And we'll also discuss later some of the advantages and disadvantages of that. And perhaps too many of these suture knots on the medial row can lead to a stress riser or cause an unfavorable recurrent tear pattern, or type 2 muscle tendon junction tear. But you have these options to tie them medially or bring them into the lateral row, these same sutures being brought into a pilot hole for a lateral anchor. And this achieves our final construct, which has two rows of anchors with the sutures connected from the medial row brought into the lateral row. So this is why it's referred to as a transosseous equivalent. You can see almost a fully transosseous connection, not quite, but done via anchors. And then the way and number of ties medially can be varied, and how you position the sutures is per surgeon preference. And many different techniques have been described. When we speak about the transosseous technique, multiple techniques have been presented, all over 20 years ago, initially by Shea in an arthroscopy, just using the simple ACL guide to try to develop a bony tunnel in the greater tuberosity. This was followed by different techniques and approaches. Fliga in 2002 presenting a giant needle technique, where this significant size needle would enter through the deltoid, grab the greater tuberosity, and exit through the deltoid near the acromion in one wide swoop. That was also presented as an idea. But this presented some very challenging technical issues, so not widely adopted. Krishnan developed the arthrotunnel, which is depicted here, connecting a vertical medial tunnel and a lateral horizontal tunnel with a disposable device. That also has some technical challenge, the reliability of it, the ability to routinely and reliably pass that suture could be difficult, but that was developed early in 2002. And then later in 2006, different curved instruments, such as this curved passer, to deliver sutures and combining that in a hybrid fashion with anchors that you could pass a suture that was delivered initially via an anchor to the lateral cortex of the tuberosity was one option. Using an endo button on the lateral cortex was another option. So these curved passers were popular. And other sort of trans-bone needle instruments similar to ACL guides by Tauber in 2008, Frick, another bone needle in 2010. And finally, Kuroda in 2013 using K-wires going from medially in a navisor position and exiting laterally. However, this also presented challenges because of where these needles and different guides would exit. They're very close to the axillary nerve. There's some concern about axillary nerve injury or placement, or presenting multiple tunnels in a stress riser fashion that might lead to a tuberosity fracture. So a lot of these were the initial challenges. So if you consider that initial technology curve, while there was hope to get away from anchors and do a fully transosseous approach, there was a lot of difficulties from the technical standpoint. However, this continues to develop, and this is a what could be considered a second or third generation instrument now. This isn't disposable, so it allows the metal to be quite firm, and it overcomes some of the initial challenges of a disposable, weaker, more flimsy instrument. This takes advantage of the tunneling approach developed initially by Krishnan with a medial vertical tunnel, just as you would place for an anchor. But now you have a very rigid instrument that can enter from a lateral portal and insert itself into that medial pilot hole that has been made by a previous awl, which is pictured here. And then this hooked device allows a inserting awl that has a suture on it to self-capture within the hook. So you can get this passing suture delivered through a bone tunnel in any location around the tuberosity from front to back, as pictured here. And this passing suture can then be used to pass definitive suture for rotator cuff repair. And the instrument is here. Again, this is a non-disposable instrument, something that can be reused and washed and repeatedly used until there's metal fatigue wear of the instrument. So this was I feel, a significant advance forward as it was reliable in that each time you pass the lateral awl or impactor with the suture, it reliably grasped itself within the bone. So it made it much more technically feasible and easier and reproducible to be on a case-to-case basis. So continuing with the technique, so that initial suture that's passed, and I'll show this by video as well at the end of this talk, additional sutures can be put through, and so now you're left with any number of sutures through each tunnel that you've created, and your repair can proceed as normal with anchors, as would be done with anchors. So the sutures can be passed through the tendon in any variety of configurations and passed directly and tied simply, as pictured here, or in a crisscross fashion to enhance your compression across the rotator cuff footprint. Again, here we see the final construct with a transosseous tunnels with suture holding the tendon down to the greater tuberosity bone. But this is fully transosseous without anchors. So the device allows you to make those tunnels. The sutures are allowing you to recreate your fully transosseous fixation. That's again pictured here in a simple format. So let's review the existing literature as it relates first to the biomechanics of these two approaches, fully transosseous approach on the one hand, and the gold standard anchored approach, or the transosseous equivalent, which I'll depict as TOE versus TO for transosseous. So what we do know from several studies, Kilcoyne, Coomer, Salata, that a transosseous equivalent approach with anchors, as depicted on the left here, has a very high failure load, higher even than a transosseous technique. So, but these are extremely high loads, 570 newtons, 468 newtons, quite high. There's also decreased gap formation in the initial construct with a transosseous equivalent anchor approach. However, compared with the transosseous technique, they do achieve significantly larger footprint coverage based on biomechanical studies, and very importantly, a lower rate of type 2 tears. So type 2 refers to tears at the muscle tendon junction, so medial to where your medial row or initial fixation of sutures are, which obviously is a much more difficult problem to address with revision surgeries, trying to repair muscle tendon junction from what is typically a type 1 tear or a bone to tendon interface where the entire tendon is removed from the bone and can be easily revised with a revision procedure. So specifically looking at the study by Kilcoyne, this was directly evaluating a transosseous equivalent anchored approach versus a transosseous technique and looking at strength. So a controlled laboratory study had 10 cadavers, excluding prior shoulder joint disease or prior rotator cuff tears. So the anchored construct is depicted here in a cadaver and the transosseous construct depicted here. As you can see, very similar final results. The testing mechanism is noted here with the muscle being attached to this plate to deliver the force for failure. So in this study, we looked at specifically maximum load, and you can see again, the transosseous anchor technique is quite high, and it was significantly higher than a tunneled technique, but the absolute value was quite high, 460 newtons, even for a transosseous approach. This in comparison to first cycle excursion to gap formation is smaller, again, for the anchored approach compared to the tunneled approach, significant in that regard. Stiffness and cyclic elongation were similar between groups. So both groups achieved high parameters, high levels in terms of our different parameters in a biomechanical study. But when we look at the failure mode, when we look at the anchored TOE technique or transosseous equivalent suture bridge approach, the majority failed in a type 2 fashion, and that's failure at the muscle tendinous junction. That's in contrast to transosseous tunnels, which the majority failed at the bone tendon interface. So a more favorable failure mode or mechanism of failure was noted in this particular study. Other studies also demonstrated that type 1 failure was noted as tendon bone and was the most common type of failure for a transosseous technique. The type 2 failure was considered to be due to excessive compression at the medial row, so maybe tying too many of the knots. Again, this is something that's more difficult to revise and leads to suboptimal outcomes. In this article by Kim in AJ7 of 2017, it's another biomechanical study looking at transosseous equivalent versus transosseous techniques in a live rabbit model. So they were measuring tissue perfusion with fluorescent dye, and they found that perfusion was significantly less in the anchored group, again, perhaps because of the constriction of the medial row of anchors. So something to keep in mind. So what are the initial conclusions from a biomechanical perspective between these two techniques? First, anchored transosseous equivalent constructs demonstrate a very high and higher failure load compared to transosseous repairs. But transosseous repairs can also achieve a high failure load. The mechanism, however, with an anchorless transosseous technique is type 1, bone tendon interface failures, compared to the transosseous equivalent anchored approach has a much higher rate of type 2 failures. And this may be due to tying those medial mattress knots. So the questions now become, are these assumptions correct? This is a biomechanical model. Does this hold true in the clinical setting? And what other factors might be associated with construct strength besides a number of factors in the construct itself? So we performed a systematic review and a meta-regression of over 40 biomechanical papers looking at rotator cuff repair constructs. So we identified the independent covariates. We specifically looked at suture type, the number of sutures. So suture type refers to, was a number 2 suture or a larger or a tape or something of that fashion. We also evaluated the number of sutures, the number of suture limbs, the number of mattress stitches, and the number of anchors used. And finally, the construct type, whether it was a double row suture bridge, as here in a single row in B, or independent double row in C versus fully transosseous in D. And then we looked at dependent variables of failure load and mode, the mechanism of failure. So the strongest predictors of repair strength are the number of suture limbs, and that refers to the number of times the suture itself is passed through the tendon, as well as the overall number of sutures, and secondarily, the type of suture, whether a tape was used versus a number 2 cord type suture. So those are the main predictors of strength. So it's all about the suture that's used versus the construct type that is performed. So when controlling for suture material, the number and type, there was no difference in rotator cuff biomechanical strength between the various construct types. So all the advocates of single row or double row or transosseous, in essence, they're all correct in that you can achieve a very high failure load with various constructs, numbers of anchors, as long as an adequate number of sutures is being used. And you'll often note when proponents of a single row approach are speaking, they often will note they're using triple loaded anchors, and that accounts for a higher number of sutures that create a higher strength construct for them. So this is true both for transosseous as well as anchored construct. Other findings, again, we noted in this systematic review that transosseous equivalent repairs were associated with more type 2 failures. So what about contact area and compression? We're always trying to achieve this surgically. So the goal of the transosseous equivalent was to compress more of the repair area than a similar 2-row construct was, and a single row construct before that. So TOE repairs have shown favorable compression areas and force compared to other anchor design. Mazaka in 2010 demonstrated this. However, the compressive ability goes hand in hand with tying the medial row. So you get greater compression as you tie the medial row, but that comes at a cost of a muscle tendon junction failure. So the greater compressive load you apply, particularly along a medial row, can put you at risk for a type 2 muscle tendon junction failure. And several studies have suggested that. So an alternative would be to not tie rows, but at the cost of less compression. And we do know, even with a very recent research coming out clinically about higher tensioning of these bridge sutures can lead to enhanced clinical healing. So these issues are all important. So with the transosseous technique, contact area and compression are advantages. There's large contact area in the transosseous technique as demonstrated by Prevela et al. In 2002. There's a favorable compression pattern. The compression is dispersed and not all focused on a single row of medial anchors. And so you can achieve high contact pressures, which have been shown to be important for clinical healing. So these studies compared transosseous, did not compare transosseous with transosseous equivalent directly, but the implications remain important. So there is a favorable compressive pattern without needing that medial row of compression when you look for a transosseous approach to this type of repair. So more biomechanical studies are needed to really sort out the balance between the compressive ability of our construct versus the risk for muscle tendon junction failure. So let's just speak a little bit about some of the drawbacks of an arthroscopic transosseous construct. The most often cited one is a suture cutout. So you can depict it here. The original tunnel was here, and you can see the sutures sort of slicing through the bone. Ultimately, in this construct, it did stop. It didn't lead to complete failure, but this is the concern that this would cut all the way through and the suture might pull out of the bone completely. So there are some solutions to this that are easy to address this problem. First one is simple augmentation. You can put a bit of an anchor type peak device that provides reinforcement for the wall, or an endo button or plate type construct. Those have all been shown to increase strength. Maybe simpler is just use of a wide suture tape, which is my preference, that spreads its force out more evenly across the tunnel instead of in one slight area that can cut through. If you position your tunnel more inferiorly along the greater tuberosity, that leads to a higher density of higher quality cortical bone, making the tunnel much stronger. So just simple positioning of your lateral tunnel more inferiorly can do that. And then finally, when you're tying your knot, if you apply the angle of pull along the lateral anchor, there isn't a force being projected superiorly. So that also minimizes your risk of cutout. There is a learning curve to this, and adapting some of those techniques does improve your outcomes. And in my experience, at this stage, the number of sutures cutting out is equivalent to the frequency I see anchors pulling out of bone. And I know we've all seen that. So those two risks are balanced, I believe, and relate more to the bone quality of the patient than the technology per se. Okay, so let's now move on to some of the clinical implications of this biomechanical data. What can this inform us? So the transosseous reports have been coming out over the past decade now. So Krishnan in 2010 at ASES presentation looking at rotator cuff integrity over 80%, very consistent with the existing literature for both open and arthroscopic approaches for a high degree of rotator cuff tear integrity. Garofalo in 2012 and Kuroda 2013 and Black in 2015, all demonstrating over 80% healing rates. With respect to clinical outcomes, initially by Frick in 2010, just simply looking at satisfaction, high satisfaction rate at 1 year. Kuroda looked at UCLA scores at 2-year follow-up, also very high. And then Black in 2015 looking at SSV scores, ASES scores, and pain at a 26-month follow-up, and all very good outcomes. And finally, 2016, an international study looked 38-month follow-up, high subjective shoulder values, great ASES scores, and simple shoulder tests. So overall, excellent clinical outcomes. These unfortunately are all isolated case series without a control group, and were the initial reports. So starting to have a good wave of optimism for this type of technology. So when we start looking at comparative studies, specifically at what's considered the gold standard for anchored construct, the transosseous equivalent versus the transosseous outcome, Seidel in 2016 had a small but retrospective matched cohort study, 21 patients in each group. And you can see the transosseous group at baseline, starting on the left, to 3 months, 6 months, and 12 months, all improved in a similar fashion with the transosseous equivalent group. And the simple shoulder test at 1 year was equivalent between groups. They did look specifically at costs and found that the transosseous group was averaging $563 compared to $1,489 for the anchored approach. And this cost differential increased based on the size of your tear, obviously based on the number of anchors you're using. Again, Black et al. Demonstrated this in the JSES in 2016, averaged $700 for transosseous compared to over $1,000 for the anchored approach. So substantial cost savings, and it's important when looking at cost savings to consider the whole global period, so to speak. So it wouldn't make sense to use a technology that might be somewhat less expensive if it required greater costs related to operating room time, for example. But that was controlled for in this study, and the operating room times were found to be equivalent. So what is the current clinical literature comparing anchors to tunnels? The limitations that we have in this initial group of literature is that it's based on case series and inadequately powered studies. So in Seidel's study, we just spoke about the comparing anchorless versus anchored repairs. There were no differences in clinical outcomes. And this unfortunately just had limited statistical power with only 21 patients in each group. More recently, 2017 now, American Journal of Sports Medicine, Rendelli et al. Looked at a randomized controlled trial of a transosseous suture technique versus a single row metal anchor, not the gold standard, but still an anchored approach. They had 69 patients, so a good number, but it was adequately powered for the primary variable of pain. So the numeric rating scale for primary pain was the primary outcome measure. They did look at constant scores, quick tests as well, but the study was not powered for those. MRI was performed, another strength of the study, and they again found no difference in clinical outcomes or cuff integrity. However, they did note post-op pain improved more quickly after a transosseous approach. So the commentary of this article by someone that submitted, Ryu et al., noted that the main limitation was that they felt the transosseous equivalent anchored approach, not a single row anchor approach, was a more appropriate comparative group for our current time. They're suggesting that to be the gold standard. And another limitation being that the study was primarily powered for pain score and not an overall patient-reported outcome score. So at 1 year follow-up, again, only quick dash was used at 3 years. So those were some of the limitations, but this is representing greater and greater evidence for the quality of literature that we're starting to see on transosseous technology. This was a randomized trial after all. So nevertheless, a recent update. This is our study looking at these two technologies. And the purpose here was try to overcome some of the limitations of prior work. While not randomized, we did seek to compare the outcomes in these two groups, anchored TOE versus anchorless transosseous repair with minimum 2-year follow-up. We seek to do this in a retrospective fashion, but with a matched cohort design. We controlled for sex, age, tear size, and smoking status. So the most important confounding variables were matched. And then we compared PRO, our ASES score, as well as looking at pain scale, range of motion, subjective shoulder value, and finally repair integrity. And that was done by ultrasound assessment at 1 year by a blinded radiologist. And we sought to have 100 patients, and this was adequately powered to detect the minimal clinical important difference for the ASES score, which is 12 points. And again, minimum 2 years with a median of actually 3 years follow-up, so extended time. So the surgical technique, again, was as previously mentioned, simple transosseous tunnels were used, no lateral augments with typically 3 sutures or tape suture combinations in each tunnel, compared to the transosseous equivalent anchored group where vented suture anchors were used. So we tried to control for the fact that in a tunnel, the bone marrow is allowed to come up to the tendon bone interface. And in the suture anchors we used, we selected a hollow-based anchor that would allow for a similar effect to try to control for this biologic phenomenon. So the patient characteristics, as you can see, are similar across groups as you would expect for a matched study. And we had mostly large tears. There was a small number of small and medium-sized tears by the Cofield classification and a few massive tears. So let's start with the results of patient-reported outcomes at 1 year. The ASES score on the left in dark blue are anchored constructs, and in light blue are the transosseous tunnels. So equivalent ASES scores at 1 year, equivalent scores at 2 years. Looking at the subjective shoulder values, similarly equivalent scores, both at 1 year post-op and 2 years post-op. Pain scores, essentially 0 at both 1 year for both groups and 2 years. So no changes, no differences between either approach. Both patient groups did quite well, regardless of technique. Looking at range of motion at 1 year and 2 year, no differences in forward flexion. 1 year and 2 year abduction, no differences between groups. And 1 year and 2 year external rotation, no differences between groups. So good range of motion, regardless of construct used. Now we move on to ultrasound determination of rotator cuff integrity. Overall, total rate of healing was 80%, very consistent with the literature. And it's very consistently based on the tear size. There were no differences between groups, only the tear sizes differed. As you'd expect, massive tears have a much higher rate of healing, rate of re-tear than smaller sized tears, which essentially all healed, small and medium sized. Large tears healed at about a 75% rate. So in conclusion, for this study, this clinical study, both groups achieved a clinical, meaningful, and statistically significant improvement in outcomes from preoperatively to both 1 and 2 year follow-up. And there were no significant differences in procedure duration, re-tear rates, and clinical outcomes between groups. The limitations, of course, it is a retrospective study and it's a single surgeon institution site, which limits external validity. However, when we look at these two techniques now from a clinical perspective, this was the first adequately powered study to show that arthroscopic fully anchorless repairs can attain similar long-term, meaning 2 to 3 year clinical outcomes to arthroscopic approaches. So clinical scores at 2 years are equivalent, re-tear rates at 1 year are equivalent, dependent on tear size, and operating room resources are equivalent. Same amount of time for both groups, and that was not statistically different. However, so when you have two techniques that are equivalent in their outcomes, a cost effectiveness analysis can be boiled down to a cost minimalization analysis, meaning if the outcomes are the same, we can simply look at their costs to determine which one presents the greatest value. So as you can see in this chart, with these lines are related to anchored constructs at various costs that you may have at different institutions and around the world, versus a transosseous construct curves down below. With an increasing size of tear, also accounted for by the increased number of anchors needed, a transosseous system does not increase in cost. So a small or a large tear can be completed with a single transosseous system versus an anchored approach where additional anchors are required. So if it's a very small tear, the costs are quite similar. If you use one anchor or one transosseous system, there's not much cost savings here, but the cost savings become much greater with larger tears and massive tears over the spectrum. So the takeaway points here are that from a biomechanical perspective, an arthroscopic, transosseous, and transosseous equivalent repairs or anchored repairs can attain similar strength. The number of sutures and the suture type, tapes over cords, predict strength to a greater degree than construct type. So transosseous repairs increase the risk of type 2 failures and may have worse compression patterns than fully transosseous constructs. From a clinical perspective, arthroscopic transosseous approaches and anchored transosseous equivalent repairs can both achieve good clinical outcomes and low re-tear rates. The arthroscopic transosseous repairs, however, because they're achieving equivalent outcomes as anchored approaches, represent higher value. There's less cost, less expense to a transosseous approach. So therefore, it can be considered a green approach. So can we go green? What else about this approach makes it green? When we adopt a transosseous technique or approach, it's an additional tool in your armamentarium. It does not necessarily supplant anchors completely or replace them. We've been in situations where an anchor has pulled out of low quality bone. We've been able to convert into a transosseous technique and complete the case. The same can be true of a suture cutting out of a tunnel and converting it to an anchored approach to complete the rotator cuff repair. So it's just an excellent skill to have and complete your surgical toolkit. However, as we drive innovation in transosseous technology, you kind of saw the progression of early techniques. It's far easier, reliable, and reproducible now than it was 10 or 20 years ago with new technology. New technologies are less disposable based. So there's an opportunity to disrupt $1 billion anchor market and drive the cost of anchors down as adoption of transosseous technology takes place. We can, in the United States, we're dealing with bundled payment models where there's a set amount of resources are committed to each case, and it's up to the surgeon or the healthcare system to decide how those resources are allocated. And in that type of environment, you're going to be very conscious of how much each implant or device costs. So this is becoming increasingly common and may be common internationally, where resources may be more restricted to be able to use a reusable device to generate a rotator cuff repair than a lot of disposable equipment. And there may be a surgical ceiling to what we're doing, whether we're using anchors or transosseous techniques. Once we achieve a certain level of biomechanical strength, and we don't even know what that number is it 300 newtons, 400 newtons, 500, there is likely no additional benefit for additional rotator cuff strength. In fact, the data would suggest that the more strength that you achieve, it's at the cost of less favorable failure mechanism, that being the muscle tendon junction failure mechanism. So with a surgical ceiling in place from our construct perspective, should we not find the most affordable way or efficient way to repair these rotator cuffs, leaving resources now to break through that ceiling, potentially with biologics or other technology? So being green in this case means less waste. Every anchor comes with a plastic handle that's disposed of each time. This less expensive instrument versus disposable implants can be used with Transosseous technology. This allows those that are in a bundled care environment or perhaps own their own surgical centers or doctor-owned hospitals to achieve a higher margin, leaving resources for other technology. And finally, it's very important from the patient perspective that the clinical outcomes are equal, and there's some indication that transosseous technique may be less painful, as indicated by a few of those studies. It's very hard to demonstrate without large trials, but it's the anecdotal experience of those of us performing transosseous techniques, as well as some indications in some of the literature as well. So for all those reasons, we present this as a green technology in the fashion described by Dr. Matson. So I'd like to proceed here with the case video, if that's okay. It's about a 10-minute video, and we'll just go through the technique.
Thank you for your interest in our presentation on arthroscopic transosseous.
I'll just narrate this here. So again, we don't have disclosures related to this instrument or technology. This case is a 63-year-old gentleman. He's a white-collar worker, office worker, recreational swimmer. It's his right shoulder, massive recurrent tear. So he previously already had an anchored repair. You can see the anchors there. It's a massive tear. There's the tendon stump, lots of fluid, lots of shoulder weakness, limiting his daily life, lifting, overhead activity, failed prior repair, re-tear on imaging we saw. In this case, muscle quality is good, maybe some grade 1 changes, 2A changes, but high quality, all the rotator cuff tendon. So the advantages we feel are tunneling now allows flexibility placed around prior anchors that are taking up the footprint. We place them adjacent, medial, or lateral with a tunnel path, avoiding those prior anchors. There are some disadvantages with an early and difficult learning curve, but it's very useful for this revision setting. So this is a beach chair positioning, 4 standard portals. This is the posterior lateral portal. We're making an incision, posterior lateral, anterolateral, anterior portals. Arthroscope enters from posteriorly. Immediately we see a massive cuff tear with old remnant sutures from the prior rotator cuff repair and the anchors. We see some labral fraying. The subscapularis here is intact. Here's a art diagram showing the tear. We place an cannula from the anterior portal to 5.5 millimeter cannula. We irrigate the joint, and a lateral portal is made with the assistance of a spinal needle. We enter there, debride the old rotator cuff footprint. Some of these sutures are debrided as well. You can see the anchor is right here where the sutures are coming from. Fortunately, this was a type 1 re-tear, so most of the tendon tore away from the bone. There isn't much of a tendon remnant. Here we're pulling out old sutures. Now we move on to mobilization of our rotator cuff tendon. This is above the glenoid. The labrum's here on the right. We're just releasing some adhesions to the glenoid rim superiorly and posteriorly. Releasing some adhesions to the subdeltoid fascia so we can maximally mobilize. And we prepare the greater tuberosity footprint. We're working from the lateral portal, visualizing from the posterior portal. Here's a burr to freshen up our footprint. You can see here the old anchor holes, so not a lot of room left to place more anchors. So here's a great use of a transosseous technology to avoid taking up your greater tuberosity bone stock with additional anchors. Here we're evaluating the cuff mobility. The cuff pattern here is primarily supraspinatus and infraspinatus. There is a slight split posteriorly as visualized right there. So it's a little bit of a reverse L, but it comes nicely over the footprint. This is an awl coming in from laterally. We're impacting it just at the articular margin right here, just as you would for an anchored approach. Instead of placing the anchor, however, after we place this pilot hole, this is the vertical tunnel. So that just created an anterior vertical tunnel. This is a posterior vertical tunnel. You can internally rotate the arm to bring the posterior aspect of the greater tuberosity forward. Here's the instrument. It's a reusable instrument that goes back and it gets washed each time and sterilized. So we flip it upside down. We curl in through a standard size portal. Then we retrovert it back. So now it's facing up and down. And that's the hook portion of the device. Now we just gently place that into the hole that we previously made, and that goes around the tuberosity. You see the lateral connecting part of the instrument. It retracts back and forth. This is the targeting awl. It has a suture placed on the awl itself. So you simply impact it. So this is another advantage. Instead of a drill, it impacts the bone around the tunnel. You release the suture, you remove that awl, and the self-grasping nature of this hook grabs the suture automatically. There's nothing to do. There's no fiddling with anything. It's automatic. It targets directly. Now you have a loop suture from the vertical tunnel through the lateral tunnel, and this is the passing suture. It's a loop. So you can choose to place any number of sutures through this loop, however you desire, which colors, which sizes. We usually typically place 2 sutures and 1 tape of differing colors to make suture management easier. That looped suture is pulled through to deliver the definitive fixation sutures. So we're doing this first in the posterior tunnel. You can see that they're sliding through the tunnel, one exiting laterally here, and then the superior sutures for repair, they're exiting superiorly. So we're relocating those in the back posterior lateral tunnel, and then we're going to repeat our steps with the tunneling device to place a second anterior tunnel. So this would normally require 2 medial row anchors, so we're placing 2 medial tunnels. The hook device again goes into that previously impacted pilot hole. You can see we're pushing down on the device to go get low. I'm going to kind of push this hook into the tuberosity, impact it down. We use a targeting lateral device to find a good spot laterally, and then we start impacting the awl. The awl, again, the clips inside the hook self-grasp that passing stitch that the awl delivered, and again passing the definitive suture through this initial looped stitch. So as you can see, it doesn't take any more or less time than placing anchors would in an anchored transosseous equivalent scenario. So now we have our sutures coming both out the anterior tunnel. We're passing those right now. The posterior tunnel is replaced, so now this is what we have. We have sutures out the medial and lateral tunnels. So now you can position this suture. We're visualizing from laterally now. We're looking into the cuff tear. We're using an instrument, a retrograde type clever hook. We can grab the sutures coming from those medial tunnels and passing it through that laminated torn area of the rotator cuff tendon. And we do that one by one. We start with the posterior tunnel. So initially a tape and then 2 sutures are passed to allow fixation of the posterior. You can also visualize from posteriorly, as noted here, and pass sutures in an anterograde fashion with a typical scorpion type anterograde device coming from laterally. You can open the jaw. This is a tape again from the anterior tunnel now, being positioned through the cuff. So very similar to how you would fix a rotator cuff with anchors, passing the sutures through. So we're finishing that. We're passing a few more sutures here from in the anterior portion of the cuff. This is the same scorpion device. And then once those sutures are passed, we can now locate them in cannula or relocate them through an anterior or different portals just to organize them. And then it's a matter of simply tying these down to each other. Instead of placing those in a lateral row of anchors, you can just tie this down with a fully transosseous compression from medial through lateral. It's a simple sliding stitch we're using because the sutures will slide just like they will in an anchor through your tunnels. So this is a sliding knot. We're delivering that knot down. In this case, we're placing the knot superiorly to compress the tendon into our footprint. And then we're placing 3 half hitches to lock that knot in place. This is the tape that we're using. I like to place that one first, again, as a strategy to protect yourself from suture cutout. Now the tape is lining the tunnel and helps protect future sutures from cutting through any bone. So the suture knot is cut, and we proceed to our next suture. You can see we've organized our sutures. Posterior tunnel sutures are draped out here, exiting laterally. Anterior sutures are draped out here. The superior sutures that are through the tendon are through a separate portal that we can grab through the cannula and then tie down. So going one by one, it is feasible and manageable. There's a slight learning curve to managing these sutures, but keeping them organized outside simplifies it, as does using different colors of sutures. So here's another tape that's being tied down. We're managing that, and then this is cutting that suture. So instead of just simple ties where you can get compression across the footprint, you can now pick two different colors of sutures from two different tunnels and cross them as well to achieve different angles of compression. This is purely surgeon preference. So that's why you see two different strands, two different colors of sutures, or two different independent sutures that have been tied together outside the body, and then their other ends tied inside the body, delivering a cross-hatched pattern and allowing for some compression across different angles of the rotator cuff tendon. Here's our final suture that we're tying down, and we're left with a construct like this. Here's a cross pattern, and then there's also some direct, simple ties as well. So here is the repair that in completed fashion. We have good compression against the tuberosity. We have no cutout. That's the old anchor from the prior surgery. We avoided that. And then there's excellent compression of the tendon into the bone. Good, we note here. So we would proceed here with any decompression or chromioplasty. We have good follow-up in this case. The patient's doing well. The rehab is identical. No changes. We've already summarized the results of some of this work. So the technical pearls, you want to do an adequate lateral bursectomy to facilitate suture passage. Inferior as possible to get better bone. You want to limit any abduction torque and tie along those tunnels to prevent any suture cutout. All right. Well, that's the end. Thank you for your attention, and happy to take questions. My contact info is here. That's my email.
Thank you, Dr. Srikumaran. That was a fantastic lecture. And I think the best point what you said was the amount of money that is saved by not using the anchors. And if you look at a cost-effective analysis, how much is the amount that is saved for one particular surgery?
Yeah, so let's take this. I mean, it obviously depends on the size of your tear, but so for an average tear, I think a lot of people would use about 4 anchors. So I think you can save easily over $1,000 per case based on this, and even more really, because especially with this device, because it's reusable, you can really develop instruments that cost, less than $100 that can be reused now. So the cost of a transosseous non-disposable instrument can be spread out over 10, 20, 30, 50 cases versus an anchors that continually have to be open for each case. So the savings can be in the thousands of dollars depending on if you're using a reusable transosseous system or not, and then the size of the tear. So if you're dealing with large and massive tears, you're probably going to save $1,000, $2,000, at least in our market. It obviously depends on how much your anchors cost. Some cost as little as $200, $250, all the way to $500, $600. So the savings can vary quite a bit based on that. But it's not only savings like we mentioned, but right, there's a lot of waste associated, plastic waste, the handles for every single anchor, those become medical waste. Those have to be disposed of in a certain way. It's very expensive to dispose of medical waste compared to just rewashing an instrument. So there's some.
The only thing is the companies wouldn't be very happy with you, isn't it?
That's right. Yeah, I'm glad you bring that up. They're not going to be happy because there's not a big revenue stream, right? So even in this system, they make the awl disposable. So there's at least something. So one awl is simply maybe $300, and that's the cost of it because you can reuse the non-disposable portion. So there's some revenue to be earned there, but it won't be comparable to an anchored system. So that's, I think, the primary reason that this technology, while it's exciting and used and has lots of advantages, it doesn't have high adoption in areas, particularly where marketing is heavy and industry has a strong presence. When I usually give this talk at meetings, and the people that are most interested come from environments where they're very cost constrained, you know, low resource settings in the world, or from surgeons that own their own ambulatory surgical center and need to drive the costs of implants down because that affects their own bottom line and the financial feasibility of their own center. So when they're motivated, when they're appropriately motivated, they're very interested in the technology. But if you're not motivated or you don't have ownership, it's still very easy to do anchors. It's very common. That's still a gold standard. But hopefully we've shown you today that the clinical and biomechanical evidence is there to support a fully arthroscopic transosseous approach.
And I really appreciate the effort that you've taken to convey this very, very strong message, because this applies to people around the globe who are not influenced by insurance and industry.
That's
For
right.
example, in a country like India, that makes a huge difference.
Yeah.
$1,000 is going to be huge.
Right.
And I'm sure a lot of patients are going to get benefited by, I mean, if they really follow this, I mean, this gets a lot of coverage, of course, and I'm sure a lot of orthopedic surgeons would see this. And when it comes from the mecca of medicine, I'm sure they're going to adopt it.
Yeah, it'll take time like anything, but I think we're on that curve. We're getting to our plateau of some productivity here slowly, but as
I, Yeah, I
yeah,
remember this statement by Prof. Ignacio Ponseti when he said when he started conservative treatment for clubfoot, the biggest resistance was the surgeons themselves, because conservative treatment is very simple
mm-hmm.
and cost effective. And he says the surgeons like their little knives.
That's right. We all have our tools that we like to use. It's very
Yeah.
difficult to change
And
minds.
I think this message is very strong. I'm sure a lot of people would see this and try to adopt in their, uh, daily practice of this simple, effective way. Let me take you to a couple of other questions that have come. One
Mm-hmm.
is regarding whether do we really need an arthroscopic cuff repair? Can we do it a mini open repair? Because the paper that we're quoting is by Andy Carr in Bone and Joint Journal,
Mm-hmm.
2017, which says that you have equal Oxford shoulder scores when compared to arthroscopic rotator cuff repair versus a mini open rotator cuff repair. What's your take on that?
Yeah, that's an excellent question. I'm glad you brought it up. As you mentioned, there is no evidence that arthroscopic repairs have better outcomes than open repairs or mini open repairs. The only evidence exists is that they're the same. The clinical outcomes can be the same. The advantages for an arthroscopic approach. So I think it's perfectly acceptable to perform open, mini open cases and achieve good results for your patients. And that can be cost effective. You can do a transosseous approach, make simple tunnels, avoid anchors in an open approach as well. So there's that. But second, there are some advantages to an arthroscopic approach. One that I mentioned was the infection rate is much smaller in any arthroscopic procedure compared to an equivalent open procedure. So the infection rate's still low, thankfully, but even a difference between 1% probably on average in the literature for open procedures compared to an arthroscopic infection rate of probably 0.1 or less. So that's an order of magnitude of 10 at least, less infections. And that's a devastating complication for a patient. In and around a joint, cartilage damage, implants are involved, sutures are involved, hard to clear the infection. So that's a tremendous advantage, I think, for the arthroscopic approach. And then again, to a point that you brought up, a lot of this is driven by patient desire. In their minds, arthroscopic is less invasive, and they prefer that approach, and they seek out surgeons that do it that way often. So that's what I think drives it a lot here and made it very popular. It is, after getting through the initial learning curve, a lot of people do it this way now. So it's available to patients to do in a less invasive manner. And, there are some benefits relating to complications. But again, the outcomes are no different between open or arthroscopic.
In the short-term outcomes, there will be a significant advantage with the arthroscopic. Like if you look at 1 month outcomes, that's going to be a lot of difference. Patients have lesser pain, faster rehab. What do you think about it?
Yeah, I mean, I favor a conservative approach anyway, so I don't perform arthroscopic cases to try to facilitate rehab. I think that's actually why open surgery has probably a little bit higher healing rate quality, because it is a little bit more painful early on. People move more slowly, and that's just a safer way to rehab and let the tendon heal before tackling, range of motion and strength. So as you said, at long term, 1 year, 2 year, everybody ends up in the same place, motion, strength, everything. So it's safest to get there slowly. If you try to accelerate early on, your re-tear rates have been shown to be higher at 3 months, 6 months for that early progression. So I avoid that. I try to get patients to go slowly as possible.
The other question is regarding the seesaw trial that was published in 2018 in Lancet, whether to do a subacromial decompression or not. So there are a lot of surgeons who believe that subacromial decompression does not offer any benefit. What is your take on that?
Yeah, from a patient-reported outcome perspective, I agree it's probably no different. But I do fairly continue to do decompressions routinely, not of the aggressive nature as initially described, but removing the spurs, creating a little bit more space, maybe for visualization during the procedure, but also just to have some more space between the acromion and the rotator cuff for recovery. So I think in order to truly understand whether it's valuable, a subacromial decompression is valuable, we would really need to look at re-tear rates and over 5 to 10 years. If the acromion has something to do with rotator cuff tears, which there is a body of evidence to suggest the acromial morphology to some extent may predispose certain people to rotator cuff tears, it's likely to happen over a very long period of time. So maybe that spur sitting there, particularly when a patient is lying flat, and just having that attrition over 5 to 10 years maybe cause a re-tear, where if you did a decompression, the rate or the length of time needed to cause a re-tear would be much longer. That study just hasn't been done. It would require a large number of people and an extended period of time. But yes, the studies that just look at clinical outcomes at 1 year, 2 year, 5 years even, there's no difference doing the decompression. But my feeling is there is a study by Dr. Verma out of Rush where they randomized it to. It was small, 40 patients in each group, but there was a trend to significance in the group looking at re-tear rates. There was a higher re-tear rate for those that didn't get a decompression. My suspicion would be during a high trial, or my hypothesis might be that there would be a higher rate of recurrent tears if you did not do a decompression. But we'll see.
The other question is regarding the coracoacromial ligament. See, when Charles Neer proposed the principles of acromioplasty, he said that you need to address the coracoacromial ligament. So what is your take on how do you approach that? Is it required? And how do you do it when you do it arthroscopically?
Yeah, so arthroscopically, we try to recess a portion of the ligament off of the spur that we feel is most prominent, and then plane that spur down to create some more space, particularly over the area of that rotator cuff tear. So it's not an aggressive acromioplasty, and we certainly don't transect the CA ligament. I mean, it's clearly important for the arch. Should this person develop a massive tear in the future, you would have wanted that arch to be preserved to avoid anterior superior escape. So it's more of a recessing off and then flattening of the acromion anteriorly with a burr. So yeah, it's not that traditional large acromioplasty with full resection of the CA ligament.
The fourth question is regarding the use of, there's a lot of industry influence on the use of PRP, platelet-rich fibrin matrix for rotator cuff, but the evidence is not very strong on the use of PRP, but still a lot of surgeons use PRP and platelet-rich fibrin matrix for cuff repairs. So what is your take on that?
I think it just comes from our desire to try to break through that surgical ceiling we spoke about. We probably achieve technically what we can with our different approaches, the strength of the repair and spreading the sutures, etc. So there's a window still. If we want to improve our outcomes from 80% healing to 90, 100%, there's a hope more than anything, a hope and a hype related to biologics to try to achieve that. So we're willing right now to throw anything in there to try to get a little bit of an edge. So you're right, the evidence isn't there for things like PRP. There might be some better evidence for bone marrow aspirate for that, but again, this is likely marketing driven. PRP is expensive, bone marrow aspirate or micro channeling the greater tuberosity. There's some evidence for that. Those are all free, easy to do. May not take off in popularity as much because they're not really driven by industry, because they're not revenue producing per se. You can easily extract bone marrow from the greater tuberosity, inject it above, or just place the channels and let the bone marrow come up. Those things probably help to some extent, but PRP or external things added, I think we're just so far away still from understanding all the complex growth factors and the timing of those growth factors over time. It's not as simple as injecting one thing one time to enhance healing. But hopefully over time, some of these bioinductive implants with the right mix of things can improve our 80% rate, slowly get it to 90%, something that's worth it. Right now they're very expensive and they haven't demonstrated less of a re-tear rate. So if we can find that less of a re-tear rate, it's worth it, because it's very expensive to do a revision surgery for the patient too. Another recovery, another year-long recovery. So some of these biologics may be worth their costs if they can be shown to reduce re-tear rates.
Thank you, Dr. Srikumaran. I think there are no more questions. Thank you for that fantastic lecture and also for the wonderful discussions that we had after that. And really enlightening. I'm sure this is going to benefit a lot of practicing shoulder surgeons all over the world.
Wonderful. If they have any questions, please don't hesitate to reach out to me. I'm happy to talk to anybody. Thank you again for your invitation. Appreciate it.
And looking forward for one more from your side.
Yeah,
one more lecture.
Anytime.
Thank you. Thank you. Bye-bye.
Bye-bye.